I'm Chris Kane from UC San Diego. It's my pleasure being with everyone this morning. I thought I'd talk about a topic of great interest to many of us over many years, and that is racial justice and prostate cancer care. Again, the disparities in the outcomes of men with prostate cancer who self-identify as Black has been visible and present since we were measuring outcomes in the 1970s. So SEER database started producing race-related or race-differentiated outcomes in the 1970s, and the incidence and death rate for men who self-identify as Black versus white has been significantly different, with Black men having nearly twice the risk of prostate cancer mortality as white men. That ratio has remained sadly similar over the years. The possible causes has been a subject of intense investigation. And there's possible inherited genetic factors, perhaps environmental factors, toxins, diet, nutritional issues. Of course, care dynamics come into play, screening behavior, treatment, and then care quality and availability, which we'll talk about is really been carefully studied recently, and that's the socioeconomics, insurance, care delivery, and quality of care. So when we look at the SEER database, on the left is the rate of new cases per 100,000 persons identified by race, and ethnicity. And you see the difference between white and Black American men with the observed ratio of 1.7 in the 2014 to 2018 age-adjusted SEER data. And on the right, we see the death rate. And again, this is death per 100,000 persons. So 17.9 for white American men, 37.4 for Black American men, again, with an odds ratio of 2.09. So twice as likely to die of prostate cancer, age-adjusted per 100,000 in 2014 to 2018. If we look at this graphically, this is the rate per 100,000. On the left side of the graph is 1973. On the right side of the graph, 1985. You see the increase in the incidence of prostate cancer associated with PSA screening around the early 1990s. But this relative ratio stays nearly constant. Again, if we look at mortality rates, we see the mortality rate for Black men and white men, both US mortality and SEER-based mortality, tracking very accurately. And again, this relative rate about 2.0 in the most recent version of the SEER database. So what are the mechanisms of these ethnic differences? And again, could it be genomic ancestry? There's been a lot of postulation that there's a quote unquote biologic difference between Black men and white men that may be making Black men susceptible to prostate cancer. And the very concept of that can be racist in and of itself, because the genetic variation of Black men is known to be very high, similar to the genetic variation of white men. So there is a concept of genomic ancestry that could be at play. So for instance, if there's inherited genes from West African ancestry, then perhaps Black men that trace their lineage back to the slave trade of West African ancestry could be at higher risk. And perhaps there's disease-causative genetic variation that leads to somatic changes in disease outcomes. But the other thing that could be at play is risk factors, exposures, behaviors that might have something to do with health outcomes. And then I think the big question mark is access, delivery, and receipt of adequate health care. So we've studied this for many years in the SEARCH database, a collaboration of the VA healthcare system between Drs. Friedland, Dr. Aronson, Dr. Amling, Cooperberg, myself, Terrace, and others. And we've looked at race and long-term prostate cancer outcomes, socioeconomic status, surgical margins and health outcomes, and equal access healthcare setting. And basically, if I show you a brief summary of the various investigations. We've actually had over 62 publications on this topic over the past 10 years. And if I were to summarize those search race articles, I would say that self-identified Black men have a higher PSA and higher grade disease at diagnosis when controlled by age. Black men appear to have a higher progression and treatment rate on active surveillance. And obese men have higher recurrence rates after surgery, regardless of race. So obesity and race are both risk factors. Lower socioeconomic status is associated with higher all-cause mortality for both Black and white men in an equal access healthcare environment. And there's no difference in skeletal-related events or overall mortality by race for men with bone metastatic prostate cancer in an equal access environment. And no difference in time to metastases for men treated with ADT for biochemical recurrence after radical prostatectomy. And again, this concept of race being a biologic concept, I think we should question. Race primarily is a social construct. The ethnic backgrounds and inheritance patterns of quote unquote self-identified Black Americans is very diverse. We now know this by SNP-based inheritance studies. The era of slavery versus modern immigration yields very different inheritance patterns. The region of African ancestry and the number of generations and region in the US all potentially influence this inherited risk. We know that communities of Black Americans are very different when studied from an ancestral inheritance pattern. There's very high variability and a high admixture of European ancestry that ranges from about 30% in the lowest admixture groups of self-identified Black Americans up to over 50%. So this idea of Black race being a homogeneous biologic construct is really not accurate any more than white race is a biologic construct. It really is much more of a social construct. So a very interesting study is the association of Black race with prostate cancer specific and other cause mortality. The senior author is Dan Spratt. And in this study, the search data was used along with other data sets. And they really asked, did Black patients with prostate cancer experience poor outcomes when known prognostic variables and access to care are controlled for? So again, the three cohorts were the SEER database, and this is uncontrolled, just observation of the men in America. The VA cohort, which is equal access healthcare, primarily a surgical group. And then the NCI RTOG cohort, which is, again, a group of randomized of patients participating in large randomized clinical trials, again, all with access to clinical trials and the excellent healthcare provided inside clinical trials. This was from 1992 to 2013. Patients received radiation therapy, surgery, or androgen deprivation therapy. And the main outcome was prostate cancer-specific mortality or other cause mortality. And again, when we looked at competing risks for prostate cancer-specific mortality, Black men appeared at higher risk in the SEER database. That's the data that I just summarized for you. But in the VA cohort and in the randomized clinical trial cohort, Black men were not at higher risk for prostate cancer-specific mortality, suggesting that access and delivery of excellent care seemed to dampen this apparent increased risk of self-identified Black men. When we look at randomized clinical trial, this is the hazard ratio for the high-risk subgroup, same results. SEER, higher risk for Black men, VA or randomized clinical trial, lower risk. And again, this is the forest plot of all-cause mortality above and all-cause mortality below, again, showing that Black men who receive better health care, even other cause and all-cause mortality differentials are dampened. So after adjusting for non-biologic differences, access to care and standardized treatment, Black race was not associated with inferior stage for stage prostate cancer specific mortality. So if we could dampen this impact, the increased mortality risk, how many men are we talking about at risk who we would be saving every year in America? And if we do the math with the census data, the number of Black men, the ratio of Black men in in America and decrease the relative risk to the white relative risk, we would be saving nearly 4,000 men dying from prostate cancer a year in America if their mortality was similar to white Americans. So there may be inherited susceptibility or other environmental impact influencing disease risk and progression in Black men. There may be subtle differences in the genomic landscape as a result of inherited or environmental factors. But we now have the strongest evidence we've ever had that providing excellent screening, detection, and treatment across the spectrum of prostate cancer will largely eliminate or at least dramatically dampen the observed differences in prostate cancer outcomes in Black Americans. So I think this is really a strong charge for all of us to be strong advocates for the access and high quality prostate cancer treatment for Black men in America. Thank you very much.